Yes, please.
Welcome everyone to our first neuro-ophthalmology webinar, Hands-on Neuro-ophthalmology. This is Dr. Sumayya Almarzouqi, neuro-ophthalmology consultant at Sheikh Shakhbut Medical City in Abu Dhabi. It's my pleasure to welcome Dr. Andrew Lee to our platform, sponsored by the Emirates Society of Ophthalmology in association with Allergan. I have worked closely with Dr. Lee in 2014 and 2015, and I learned so much during that short time. Dr. Lee is the chair of the Blanton Eye Institute at the Houston Methodist Hospital in Houston, Texas. He is the professor of ophthalmology, neurology, and neurosurgery at Will Cornell Medicine. He holds joint appointment at Baylor College of Medicine, Texas, A&M College of Medicine, the University of Iowa, the University of Buffalo, University of Texas Medical Branch, and the UT MD Anderson Cancer Center. He has published over 500 peer-reviewed publications and 8 full textbooks in ophthalmology. He has been the invited speaker at over 300 national and international eye meetings. But one more thing for sure is special about Dr. Lee, he captivates his audience with his talks. He has the ability to make the difficult topics so easy to understand. We have 3 talks in our webinar. I hope you will enjoy all of them. The questions will be at the end of the last talk. So let us learn more from the Master in Neuro-ophthalmology, and we'll start with our first topic, 5 easy mistakes to avoid in your next neuro-ophthalmic patient. Dr. Lee, the floor is yours now.
I appreciate the invitation to speak with you. I'm sorry I can't be with you in person. I've been to Abu Dhabi many times and to the Emirates, and it's a beautiful country. So I want to recognize Sumayya for all the work she's been doing in your country and spreading the good word on neuro-ophthalmology. And hopefully at the end, we'll have some time for questions. So the first talk is 5 easy mistakes to avoid in your next neuro-ophthalmic patient. And so, as Sumayya mentioned to you, I serve at a number of academic institutions. And so one of the subtitles of the talk is helping my residents understand what to say and what to not say. So we call those sins of commission and sins of omission. So hopefully by the end of this talk, you'll know, say this, not that. And the reality is, unlike a lot of ophthalmology, neuro-ophthalmology is one of the specialties where what you do and the decisions you make can save people's lives. So this talk is going to put you outside of your comfort zone, which is a good thing, and hopefully it'll generate a lot of questions. The real question, though, at the end of the talk is, why did you go to medical school? I think the answer is easy. You went to medical school to be a medical doctor, but the larger question is, when you're an ophthalmologist, being a medical doctor means thinking about things in a medical way first. And so when I travel, and I haven't done any travel in 2020 because of COVID-19, but normally when I travel and they make that call in the airplane, is there a doctor on this aircraft? As an ophthalmologist, it's a hard decision to make. Am I a doctor or not? Especially when I'm walking past rows and rows of people who look not very healthy. I wrote it up, my first experience with this. You can go look up this article. It's called, I'm Not a Doctor, I'm not an Ophthalmologist. Of course, now that I'm a neuro-ophthalmologist, I believe the exact opposite. And the reason I believe this is you don't have to like neuro-ophthalmology. You don't have to do neuro-ophthalmology, but you do have to respect neuro-op. You don't even have to like me, but you have to respect neuro-op. And neuro-op is one of those specialties where if we make the wrong decision, we can really cause a lot of problems. So if you look in the United States, if you just ask our patients, who is a medical doctor, and you can see the easy ones, orthopedic surgery, but then when you start getting down to dentists and psychiatrists, and we're kind of dropping a little bit. And the reason we're dropping is because we don't take our role seriously, and then other people don't take our role seriously. So your role as an ophthalmologist really is to be a medical doctor. And that means being a medical doctor first, an ophthalmologist second, and a refractive surgeon or a vitreoretinal surgeon or an oculoplastic surgeon third. So this is what I want to cover today. I want to cover the key symptoms and signs that make a diagnosis and the importance of keeping those three boxes separate. The symptom box separated from the sign box, separated from the diagnosis and the impression box. And the reason that needs to be done like that is to avoid premature closure of the differential diagnosis. If you write what you think it is in the sign box, it'll lead to closure of the differential, and you won't be able to make the ultimate decision, which is what is really wrong with this person. And so one of the main take-home messages I want to leave you with is don't let sewage creep into your record. And what I mean by that is make sure that each part of your record is clean. And if you let even just a little bit of sewage inside to the record, it'll ruin the whole thing. A differential diagnosis is mandatory in this setting. And I'm going to share with you some of the rules, which are the heuristics for teaching and learning, but please don't make up your own rules. And the most common way we make up rules is to take a one-way heuristic, A to B, and make it into a B to A, and we really don't want to do that. So just a general ophthalmologist dealing with the problems that we're going to be talking about today, the life-threatening and the vision-threatening problems in neuro-op, you really only have two choices. Either you can work it up or you can recognize, triage, and refer it. And so my father would say, what do you call a teaspoon of wine in a barrel full of sewage? It's sewage. What do you call a teaspoon of sewage in a barrel full of wine? That's also sewage. So we cannot let that one even teaspoon of sewage creep into our barrel of wine because it'll ruin the record. So one of the first things we do in medicine is we get the chief complaint. And I know that they teach you to get the chief complaint as in the patient's own words, in quotes, whatever they say, that's their chief complaint. And I have found over the years that that is not a very effective strategy for creating a working hypothesis. So we'd like to know what the patient's chief complaint is in their own words, but also we'd like to know the tempo, whether it's painful or painless, and then develop a working hypothesis just from that initial chief complaint. So even if the eye exam is normal, we need to know what the chief complaint is. So for example, here's a 75-year-old white female who has acute severe headache and scalp pain. And the impression is normal eye exam. Please don't do this. So this is a don't do this. This is one of the biggest easy mistakes to avoid, which is having a normal eye exam is not a diagnosis. Whatever their chief complaint is, we must address it. And if you just write impression normal eye exam, you really didn't address their chief complaint. So instead of doing that, which I'm recommending against, I'd like you to do this, right? Impression, 75-year-old white female with new onset headache, scalp pain, and that's going to direct your thinking towards giant cell arteritis, and that will make your plan stat, sedimentation rate, C-reactive proteins, steroids, and or refer. So the major behavior change in terms of the chief complaint that I would like to leave you with in this first talk is don't write a symptom or a sign as the diagnosis. So impression, diplopia, that's a symptom, not a diagnosis. Impression, ptosis, that's not a diagnosis, that's a sign. And the same goes for esotropia, and certainly normal eye exam is definitely not a diagnosis. Likewise, for retina cases, not the retina is not a diagnosis. Dilated is not a pupil exam. Vision too terrible to have a visual field is not a visual field exam. Dilated right eye only, that is not a full exam. So all of these I have seen in the real world. They are such easy mistakes to avoid. And I hope that it's obvious to you now that the way to avoid these mistakes is to know that they're mistakes to begin with. So it's very common and very easy to end up with a chart that looks like this, impression, ptosis. But as I mentioned to you, ptosis is not a diagnosis. In addition, there's no differential attached to this ptosis. And the worst thing that can happen is once you get premature closure of the differential and you end up writing ptosis, then the next thing you're going to write is planned ptosis repair. When in reality, I don't want you to do that. I want you to do this instead. Impression, ptosis, secondary to levator dehiscence in the right eye, no evidence for myasthenia, no third nerve palsy, no Horner syndrome. So what you're really writing in the chart here is it's not neuro-ophthalmology. And that is the most important lesson that you can have on what should you be doing. It's okay to miss a ptosis if it's not neuro-ophthalmic, because it's very uncommon that a ptosis that's not neuro-ophthalmic, alleviator dehiscence or traumatic, is going to be harmful to the patient. So Sumayya has been my fellow, so she knows this already to be true. I tell all my residents and fellows that one day you're going to hear my voice in your head. It might be a Friday or a Saturday. It might be a holiday, and you're going to hear my voice. Even if it's Saturday night, the devil on your shoulder is going to be speaking to you to tell that patient to come on Monday, but then you will hear my voice, and hopefully hearing my voice on this lecture will be enough to convince you not to make these mistakes. So when we move from the chief complaint to the next thing on the list, I know it's tempting to go straight to the history of present illness, but the past medical history is actually way more important. We'll put the context on the chief complaint. So the chief complaint establishes the working hypothesis, what you're trying to do. And even though it seems like you should go next to history of present illness, what you really should be going to next is the past medical history. So don't do this, PMH, past medical history, lung cancer. That's not enough information to provide us with the key parts of the information that we need, which is how dangerous is this case. So I'd like you to write instead past medical history of how bad it was, the stage, the grade, and the treatment. So past medical history, stage 4, small cell carcinoma of the lung, status post upper lobectomy, and resection last month, now on chemotherapy, radiation therapy with known metastasis to the liver and bone. So if you compare these two past medical histories, number 1, incidental lung nodule found, stage 1 adenocarcinoma resected in 1985, no chemotherapy, no radiation, no metastatic disease, and had a chest x-ray last month, which is stable. Those two patients both actually have the same past medical history, lung cancer. But in a 65-year-old white male who has a new optic neuropathy and loss of vision in the right eye, one of these patients is really likely to have metastatic carcinoma, and of course, it's the one that has stage 4. But if you just write past medical history lung cancer, you really don't know which person is the risk of having the cancer. So if we're in the exam now, the things not to do, mostly the exam mistakes that I see are in the pupil exam and the fundus. The most common pupil exam problem is writing pupil equal round reactive to light and accommodation. That's a very common abbreviation in the English language for the pupil exam. I think it's a terrible way to document the pupil because there's no assessment of the anisocoria in the dark. There's no assessment of the RAPD. So every pupil exam needs to have 4 components. What does the pupil look like in the light? What does the pupil look like in the dark? What is the reactivity of the light to near and to the light, and whether there is or is not a relative afferent pupillary defect. So I would recommend to you that you record your pupils like this: pupil P, 5 millimeters to 3 millimeters OU, no RAPD. If you don't have a pupil exam, for example, it says this, pupils, and it's got a mydriasil and a neosinephrine dilated 2:45 p.m. That is a documentation that you didn't do any pupil exam. That is a really, really dangerous thing to do. So here's the patient. They're referred for levator dehiscence. They're about to have surgery because they have this high indistinct lid crease. The tech has written PERLA, pupil equal round and reactive to light. In fact, they're already wearing that hat to go to surgery, and you can see the left upper lid ptosis there. And it's very, very dangerous to operate on these people without a clear pupil exam. So even the most mild ptosis can be something bad. In this particular example, you can see the high indistinct lid crease in both sides. And I would challenge any oculoplastic surgeon to look at these pupils and determine that there's anisocoria. You need to look for anisocoria in this patient in the dark. So here's the patient in the light and in the dark. And now in the dark panel, you can see the anisocoria is so much more obvious. We're going to put aproclonidine in this eye, which is an alpha agonist, and we'll reverse the anisocoria. So as the anisocoria is reversed here, this is a pharmacologically confirmed Horner syndrome. You're going to be thinking about the most dangerous thing here, which is the carotid dissection. Obviously, if there's a history of trauma, that makes it more likely to be dissection in the carotid, neck pain, the Horner syndrome, transient vision loss, or branch or central retinal artery occlusion are all clues, and a bad taste in the mouth, that's dysgeusia. That is from the choroid tympani. So here's what we're looking for radiographically in these patients: a crescent sign of hyperintense signals surrounding the dark flow void in the ipsilateral carotid artery. And you can see in this patient, we have no flow in the ipsilateral carotid. You can see the normal carotid flow void on the left compared with no flow on the right. And on the MRA, the same thing. There's no flow on this carotid. So this is a life-threatening cause of Horner syndrome, a carotid dissection. The second thing in the exam is documenting what you see, not what you think it is. So here's a visual field that you can clearly see there's a hemianopic field component to it. And there's a little bit of a superior temporal field defect in the fellow eye. It's going to be very tempting for you to think this is glaucoma, but if you just write down what you see. So instead of writing that you see bilateral arcuate defects, your main job is to make sure that this is not a hemianopic field defect. So if we have respect to the vertical meridian and it's bitemporal, that is a bitemporal hemianopsia. Of course, they just kept repeating the visual field over and over again, and now you can see it's so obvious that it's a bitemporal hemianopsia. And of course, it was an intracellular mass. You can see the supercellular extension here of this sagittal view of the pituitary adenoma producing those quote-unquote bilateral arcuate defects. So always look at the visual field with neuro-op in mind. Is it bitemporal or is it homonymous? Any respect to the vertical meridian is going to be significant. So whenever you're looking at fields, instead of just attributing it to glaucoma, even if it looks arcuate in shape, you must ask yourself the question, is it homonymous? Is it bitemporal? Is it respecting the vertical meridian? And if yes, you should image it. And the reason is, the book makes it seem so easy. The book Bitemporal Hemianopsia is clearly a bitemporal hemianopic field defect, and you can see from the real world patient, that patient I just showed you, it can mimic what looks like an arcuate defect. It can look very subtle. So don't be waiting for the book Bitemporal. That is a big mistake that you can avoid. And then finally, in the diagnosis box, we want to avoid a premature closure of the differential diagnosis. And one of the things that happens is you end up writing what you think it is, but you don't have a differential. So please don't write ischemic optic neuropathy unless it is ischemic optic neuropathy. And that means making sure that the patient has risk factors, has a swollen disc, a small cup to disc ratio in the fellow eye, and making sure it's not giant cell arteritis. Ischemic optic neuropathy is not an etiologic diagnosis. Even anterior ischemic optic neuropathy is not an etiologic diagnosis, because of course there are two forms of AION. There's the non-arteritic form, which is not giant cell, and the arteritic form. And so it's super dangerous to write things like ION, ischemic optic neuropathy, or even AION without excluding GCA, which is the arteritic form, or at least having a differential diagnosis. The worst thing you can do is write fake news in the chart, and the fake news thing that we see often is ischemic optic neuritis. There is no such thing as ischemic optic neuritis. It's either optic neuritis or it's ischemic optic neuropathy. You really have to pick one. And in an elderly patient who has this on their chart, you really should be thinking about giant cell arteritis rather than optic neuritis. And sometimes the disc is pale and swollen at the same time. That pallid edema can make it look like there's no disc edema, and that is a very, very dangerous thing. So one of the teaching points I'd like to leave you with is don't make up your own rules. And one of the rules that we kind of make up is if there's a nerve that's not swollen, that is retrobulbar optic neuritis. If the nerve is not swollen, it just means it's retrobulbar. You don't know whether it's optic neuritis or optic neuropathy from ischemia. And of course, in the retrobulbar form, that we call that posterior ischemic optic neuropathy. And of course, here in the United States, and probably in your expat population in the Emirates, a white female who has giant cell is going to have temporal tenderness, and that one is so easy to diagnose. It just says on the forehead, I have giant cell arteritis. The one that's difficult, and the one that I want to warn you about, is when the patient doesn't have any disc edema. So this patient was seen by a retina specialist and was told it's optic neuropathy, which it is. It's a retrobulbar optic neuropathy, and then they went straight to optic neuritis. And you can see if they had just done the fluorescein, which is what retina should have done, we can see the massive choroidal non-perfusion deficit between the medial and lateral choroidal artery. This does not occur in retrobulbar optic neuritis and is the clue that this patient has giant cell arteritis. So optic neuritis is a young person thing. You really should be very worried about the diagnosis in elderly patients, although retrobulbar optic neuritis is the most common cause of retrobulbar optic neuropathy and demyelinating disease. If you see it in an elderly person, that's more likely to be posterior ischemic optic neuropathy. So please don't write 80-year-old with optic neuritis. An 80-year-old can have optic neuritis, but it's just so rare. So we really want to be thinking about ischemic optic neuropathy, and please don't write ischemic optic neuritis because there's no such thing. Here's a patient who has a little tiny field defect, and if you apply my rules, as I mentioned before, this is a 2-eye thing. You're going to be looking at that vertical meridian. You're going to see that this is a bilateral, homonymous, denser inferiorly, paracentral homonymous hemianopsia. And that lesion is actually a very big lesion, the occipital cortex, because a lot of real estate is being devoted to this central field. So the size doesn't matter. And in the retina charts, it used to be that retina was really great at documenting what they saw. But in the modern era, the electronic medical record has taken over for the documentation of retina. So we really don't get to see what they saw anymore. It used to be they just drew what they saw. And I would hope that you would go back to that old style. If you see something, just draw it. Because it's very difficult to put into words what a drawing can. And if you're not good at drawing, just take a photograph of it. It's just so much easier. And the templates that we are seeing for these Word documents are dangerous in the EMR for ophthalmology. And once that gets in there, that is the sewage I'm talking about. So here's an example of something's not right. You can see that in this clock, the 4 here is not a Roman numeral 4. The 4 is a 1 and a V. So an I and a V is the actual 4. But once it gets in there, once that little bit of sewage gets in there, it just perpetuates. And so that's the same thing that happens in the electronic medical record. Once somebody writes Bell's palsy in the chart, even if it was myasthenia-related 7th, it's just going to keep carrying forward over and over and over again. And so that's what I mean by please don't let that little bit of sewage get into your chart. So in summary, hopefully this little overview has been about not making some easy mistakes. The most common mistakes that I see being made in ophthalmic charts is not keeping the symptom separated from the sign, separated from the diagnosis. If you put the sign or the symptom in the diagnosis box, you'll get premature closure. And ptosis is not a diagnosis. That's a sign. Diplopia is not a diagnosis. That's a symptom. You must have a differential. Number 2, please don't let sewage of any kind seep into your record. The most common sewage that we see is that patients have in their chart something that isn't true or that represents a wrong diagnosis, and then it's hard to get rid of it. Please have a differential diagnosis, even if there is no differential diagnosis. So even in patients who have what looks like ischemic optic neuropathy, you still must consider both the arteritic and non-arteritic forms. And please don't give patients optic neuritis as a diagnosis just because it's retrobulbar. Don't make up your own neuro-op rules. The rules are a one-way heuristic. And what I mean by that is, if you see a swollen nerve and the nerve is in the patient with the vasculopathic risk factors, that means it's likely to be non-arteritic anterior ischemic optic neuropathy. But the reverse is not true. If you don't see that, that doesn't mean that it's not ischemic, and it doesn't mean that it's not giant cell. So you need to be thinking about giant cell in those circumstances. And then finally, the most important lesson that I want to leave you with is when we're seeing a patient, you really only have 2 choices. You can either work it up or you can recognize, triage, and refer. So don't be using that template for every patient. The key question is this neuro-op, yes or no? And I want to make sure that I leave you with a message of hope, which is these are my children, and I think that one of the things I teach them is to do these same things. These sins of commission and omission are the same sins that we commit in life every day. So don't take the shortcut, don't do the easy thing. And finally, the most important message that I want to leave you with, you went to medical school for a reason. That reason was to be a medical doctor. You're a real doctor, no matter what anybody else says. including yourself. And I hope you'll be the doctor that your mother already thinks you are. And I thank you for your time and attention for this first talk. Sumayya, I guess I'll turn it back over to you. Are you still there? You can keep going. I'm hoping you can. The second talk is ready. We can just go.
Professor.
Okay, Sumayya says keep going.
Yes, please.
So after that little short breather, the second talk segues from the first talk because the second talk is about mistakes and diagnoses, but in the reverse. Diagnoses that you as a comprehensive ophthalmologist probably should be not making by yourself. So these 5 diagnoses all have unifying features that make them particularly dangerous. So you shouldn't make these by yourself. You already heard about one, posterior ischemic optic neuropathy. That's a diagnosis of exclusion. And the reason is there's no way for you to make that diagnosis. It's a diagnosis we have to make in retrospect. Third nerve palsy, which is rule out aneurysm. That's super important. Chronic optic neuritis, and you really heard about optic neuritis, but the chronic form does exist, but it's dangerous. The Tolosa-Hunt syndrome and idiopathic painful granulomatous ophthalmoplegia from cavernous sinus involvement and retinal migraine. You shouldn't be making that diagnosis anyway, but you should definitely not make that diagnosis on the first attack. So let's just start with the unifying principles for all 3 of these conditions. All 5 of these conditions rather, share common characteristics. First of all, there are real diagnoses, but they're just diagnoses that you as a comprehensive ophthalmologist should not make by yourself. Number 1, there's no diagnostic test that establishes a diagnosis. It's what we call a retrospective diagnosis. You can only say someone had PION after the event, not during it. Same with Tolosa-Hunt. It's a diagnosis of exclusion. Number 2, diagnosis of exclusion means you have to work it up. You can't just start with the idiopathic diagnosis of Tolosa-Hunt. And the worst thing about it is the alternative etiologies, the things that it could be other than Tolosa-Hunt, are very dangerous. And they often have negative imaging or near normal imaging, which makes them very dangerous because you get this false sense of security. So for all 5 of these diagnoses, you need to make sure that they either resolve or at least are stable at follow-up. And I would recommend you refer all of these cases, but especially if it's progressive or atypical in any way. So the first one you already heard a little bit about, which is called posterior ischemic optic neuropathy. As you know, the posterior refers to the fact that the nerve is not swollen. So in anterior ischemic optic neuropathy, there's swelling of the nerve because it's anterior to the lamina curvosa. So that anterior swelling is what we see ophthalmoscopically. And if you don't see the swelling, that is a retrobulbar optic neuropathy, and the most common thing that we see that in is retrobulbar optic neuritis. However, in older patients, you really have to worry about PION. So there's 3 areas where PION occurs. The first is the most important one, giant cell arteritis. So if you see a retrobulbar optic neuropathy acutely in an elderly patient, you really should be thinking about arteritic AION at the top of the list. The non-arteritic form that you need to know about is after surgery, but not ocular surgeries, non-ocular surgery. And the 2 non-ocular surgeries that we see this after are lumbar spine or other spine surgery and cardiac surgery. And then non-arteritic PION, as opposed to non-arteritic AION, is very, very rare. And so that's why I think you should not be making the diagnosis of PION by yourself. So you really shouldn't be writing down retrobulbar optic neuritis in an elderly person. It could be retrobulbar optic neuritis, but usually it's something bad. The retrobulbar optic neuritis in elderly patient that you should be worried about is giant cell, but it doesn't have to be inflammatory. It could be a compressive lesion. So that's the same way that pituitary apoplexy appears, or fungal disease. And if you give steroids thinking it's giant cell, but it's fungal disease like aspergillosis, you're actually going to make the person worse. So even though steroid is the treatment for retrobulbar optic neuritis, you really have to have a scan of every patient with retrobulbar optic neuropathy, even if you think it's PION. And I mentioned that, of course, patients don't come in with the diagnosis written on their forehead, but if they do, the diagnosis is giant cell arteritis. And one of the things that you need to be thinking of in PION is doing a fluorescein angiogram. OCT has kind of taken over the workup of retinal disease. However, there's some things that OCT cannot see. And one of the things that OCT cannot see is perfusion. And so PION, a retrobulbar optic neuropathy in an elderly person, really should have a fluorescein angiogram. And what we're looking for is this choroidal non-perfusion here. That choroidal non-perfusion does not occur in demyelinating optic neuritis. So really you should be thinking about doing a fluorescein angiogram in every patient who has a retrobulbar optic neuropathy, but especially if you think it's PION. Because if you think it's posterior ischemic optic neuropathy and we see this choroidal non-perfusion, then we're really going to be thinking about vasculitis. And of course, the most common vasculitis that we see in the elderly is giant cell. So when would I accept the diagnosis of PION, posterior ischemic optic neuropathy? I will accept this diagnosis if they've had non-ocular surgery like spine surgery or cardiac surgery and they wake up with vision loss in the recovery room, or if they have giant cell. If they don't have that, you should really be doing an MRI. I would recommend you do a fundus fluorescein angiogram to look for the choroidal perfusion defect. They better have an RAPD to make sure that it really is an optic neuropathy. And over time, the normal disc will become a pale disc, and that means optic atrophy will develop over time, and then it has to stay stable over time. So I would make sure that you have excluded fungus before giving steroids. But of course, if the imaging study is negative or it shows that it's not optic neuritis, or even if it is optic neuritis, I would give the patient steroids, but only after excluding fungus. So the bottom line is, please don't make the diagnosis of optic neuritis in elderly patients. The range in the optic neuritis treatment trial, the ONTT, was 18 to 46. So once you get starting to have patients 80, 70 years old, you really should be thinking about PION in that setting. Here's a patient who has a complete ptosis, and they have a third nerve palsy. Of course, you all are familiar with the rule of the pupil. A rule of the pupil is a third nerve palsy with the pupil involved and pain is an aneurysm here of the posterior communicating artery until proven otherwise. It's super important that we make the diagnosis of third nerve palsy because once we have the aneurysm identified, we can put a stent and then coil this aneurysm and go home hospital day 3. If we let it rupture, half the people die at the scene. The people that make it to the hospital, half of those people are permanently neurologically impaired. And so I don't think that a general ophthalmologist should manage third nerve palsy at all, let alone a pupil-involved third nerve palsy. So in my opinion, third nerve palsy is just on the list now of you probably shouldn't be working that up. You probably should be referring that. And normally that means going to the hospital if it's an acute setting. So in the hospital, we're going to start with a non-contrast CT. That's to look for subarachnoid hemorrhage. And then we're going to do a CTA to look for the PCOM aneurysm. It's going to be followed by an MRI, MRA with and without contrast. And that's because MRI scans are better than CT scans for the non-aneurysmal causes of third nerve palsy. And if we still think they have an aneurysm, we're going to go straight to the gold standard. That is digital subtraction angiography, catheter angiogram. The bottom line is, the reason you shouldn't be fooling around with third nerve palsy as an ophthalmologist is you need an angiogram of some kind to find an A, and that A is aneurysm. And if you start working it up, you might get an MRI, which is normal, but there is no A in MRI, and that means you just made a big mistake. So I don't believe that general ophthalmologists should make the diagnosis of third nerve palsy with or without the pupil by themselves. This is a patient who's 25. She has new onset pain with eye movement. She had loss of vision in her right eye. She had a right RAPD. She had a central scotoma. She has a normal disc. Diagnosis, retrobulbar optic neuritis. So that is a very super common way for optic neuritis to present. And if you look at the cumulative rates of recovery of normal visual acuity within the first 6 months in the optic neuritis treatment trial, if you look at months of study compared with how many people got their vision back, and in the optic neuritis treatment trial, there were 3 arms: intravenous methylprednisolone, placebo, and oral steroids. All 3 groups got better. So all optic neuritis patients pretty much get better. I would say less than 5% of people don't get their vision back. Same thing with the visual field. You can see the cumulative rates of recovery of a normal visual field in the first 6 months. And you can see that the fields and the vision get better faster with intravenous steroids, but that everybody ends up getting better. So intravenous steroids makes people get better faster, but doesn't change their final outcome. But what if you see the patient back in follow-up and they're not better? So that we call chronic optic neuritis. And chronic optic neuritis does exist. It typically occurs in the setting of bad multiple sclerosis. So they have secondary progressive MS rather than having relapsing remitting course. They have a progressive secondary course. This is a diagnosis of exclusion. So if your optic neuritis patient doesn't get better, especially if it's a man, you really should be thinking about alternative etiologies, including labor hereditary optic neuropathy, which can present with an MS-like illness. Most optic neuritis just gets better with or without steroids. Less than 3% of patients are 2200 or worse. And if they're not getting better, the other thing you have to worry about in chronic optic neuritis is NMO, an antibody disease, and also MOG, myelin oligodendrocytic glycoprotein. So one of the things that you need to know about this optic neuritis thing is normally there's only a short segment of intraorbital enhancement in optic neuritis. So if we see bilateral or longitudinally extensive enhancement, or if the vision is terrible, these are the people you really should be thinking that maybe they have NMO or MOG, neuromyelitis optica. And in the past, it was relatively easy to make the diagnosis because they had to have the myelitis. But now we know that the optic neuritis can precede the myelitis, and some of the patients don't have the myelitis for years. So here's the myelitis patient with longitudinally extensive T2 change, and in the NMO patients, they have 3 vertebral segments or more to define the longitudinally extensive. So if we see longitudinally extensive enhancement either in the spine, 3 vertebral segments, or in the optic nerve or in the chiasm, you really should be thinking about other causes of optic neuritis other than MS, and the ones to be thinking about are the antibody-mediated forms, neuromyelitis optica and myelin oligodendrocytic glycoprotein. So in my clinic, I'm going to be ordering NMO and MOG in patients who have long spine segments or multiple episodes of optic neuritis. Probably any spine, I'm going to do it. It's not clear whether we should be doing it on every single patient with optic neuritis. I personally don't order the NMO and MOG if there are white matter lesions consistent with MS, but you could do it. And the reason it's important is MS is a relapsing remitting disease that requires immunomodulatory therapy, but NMO and probably MOG as well require immunosuppressive therapy, not immunomodulatory therapy. So if you see a patient that doesn't recover their vision after optic neuritis or has quote-unquote chronic optic neuritis, you probably shouldn't be evaluating that by yourself because that could be the MS mimic, NMO or MOG. It has a very unpredictable course, and if you give the wrong therapy, immunomodulatory therapy for MS makes NMO worse. So if you look at the number of patients where this is a very important diagnosis to make, if you look at the cumulative time-related interval for NMO positive, the red line, versus NMO negative, the dashed line, to develop a transverse myelitis event, which is paralysis, or another optic neuritis event, you can see that a large percentage of these people are going to have transverse myelitis in the first year. And so they're going to get paralyzed. So it's really important that we not make the diagnosis of chronic optic neuritis and that we recognize that we should be looking for NMO, not because we're going to bring the vision back. You're probably not. The goal is to get the diagnosis so they can get immunosuppression to prevent the transverse myelitis event that is coming if you don't make the diagnosis at time 0. And here's just a different way of looking at it. NMO positive in the red, and this is time to getting another attack of optic neuritis. And you can see if you're NMO negative, there's a risk of getting a recurrence. But look at the risk of getting another attack if you are NMO positive within the first several years. So it's really important that we make the diagnosis of NMO and probably also MOG in these patients with quote-unquote chronic optic neuritis. So when do I order the NMO antibody? I order the NMO antibody if you don't recover, and that's what we used to call chronic optic neuritis. So who knows how many chronic optic neuritis patients that I saw in the past that just said, look, it's bad luck, that's 3% of the cases, actually were harboring antibody-mediated NMO or MOG. If it's bilateral or sequential, or if it's recurrent, but especially if the MRI scan does not show the white matter lesions that we normally would expect in multiple sclerosis. In addition, a very large CSF pleocytosis of 50 white cells or more, that also is very atypical for multiple sclerosis and should prompt consideration for NMO. And then, of course, the obvious, easy one, if you have transverse myelitis, of course, you should be thinking about neuromyelitis. So when would I accept this diagnosis of quote-unquote chronic optic neuritis? I would accept this diagnosis if I have done an MRI and I've ruled out a compressive lesion. As I said, and as is true with the other conditions, it is a diagnosis of exclusion. I prefer an MRI head, orbit, gadolinium, fat suppression. And you have to have MS. You can't be giving the diagnosis of chronic optic neuritis to people who don't have MS. And in fact, if they don't have the MS white matter lesions, you really should be thinking about NMO and MOG. I always tell the treating neurologist that, look, this person didn't get better, so that they know that it could be MS, but they have to look for the MS mimics and the MS-like disorders, including the antibody-mediated MS-like disorder, NMO and MOG. And finally, if it's a man, especially if it's painless loss of vision and a central scotoma, you need to be thinking about Leber hereditary optic neuropathy, even if they presented with an MS-like illness. Getting to the home stretch now, Tolosa-Hunt syndrome. Tolosa-Hunt syndrome is a painful ophthalmoplegia. It's got negative imaging or maybe just some enhancement or asymmetry in the cavernous sinus. It's exquisitely steroid responsive. It's also a diagnosis of exclusion. Because Tolosa and Hunt practiced in the pre-MRI era, most of the Tolosa-Hunt that I see is Tolosa-not. This is Dr. Tolosa and Dr. Hunt. You can see it's a black and white photograph because they practiced and wrote their papers in the 60s. This was before CT and MRI. And the big caveats to Tolosa-Hunt syndrome are a lot of bad things cause painful steroid responsive ophthalmoplegia. Being steroid responsive does not mean it's inflammatory disease. Sarcoidosis will get better, but so will lymphoma and metastasis. And if they have a concomitant optic neuropathy, that means whatever it is extending into the orbital apex. And even though that can occur in Tolosa-Hunt, it's a big red flag. And the thing that I always worry about in those cases is fungus. It's super dangerous because fungi don't have any water. They're just dried out fungal hyphae, and so they look black on T2 and can be invisible on MRI without the contrast material and fat suppression. And if you give steroids to this Tolosa-Hunt and it's fungus, you'll have fungus among us. It just makes it worse. And of course, just like with all the other dangerous diagnoses, there's no diagnostic test to prove that it's Tolosa-Hunt. In fact, Tolosa-Hunt syndrome is a fancy way of saying I have no idea, but other people had it too, and their names were Dr. Tolosa and their Dr. Hunt, and they wrote up a few cases. So really, it's just saying idiopathic. Idiopathic, of course, is the last diagnosis. It should never be the first diagnosis. And CT scan is completely insufficient for making this diagnosis. You really have to have an MRI scan. So I would say to you, you should beware any steroid-responsive painful ophthalmoplegia, and you definitely should not be making the diagnosis of Tolosa-Hunt syndrome on your own. If you look at their papers, Tolosa in 54, Tolosa in 1961, and Hunt in 1961, that was before we even had a CAT scanner, let alone an MRI. So if you look at the Tolosa-Hunt diagnostic criteria in the literature, you have to have one or more episodes of unilateral orbital pain that persists for several weeks if untreated, and then you have to have ocular motor cranial neuropathy, paresis of cranial nerve 3, 4, or 6. You have to either have the granuloma on biopsy, which we almost never have, or you have asymmetry in the cavernous sinus, and it has to get better within 72 hours of starting the steroids on the pain, and the paresis has to get better too, and that means it's a diagnosis of exclusion. You had Tolosa-Hunt, we treated it with steroids, you got better, and it did not recur, and you had both clinical and radiographic improvement over time. Lamancia et al. Look at this at the literature and published in Cephalgia in 2006 of all the cases of Tolosa Hunt published up until that time. Only 21% of the 208 cases they reviewed would actually meet the current diagnostic criteria for Tolosa Hunt syndrome. And half the cases had negative CTs, even though later MRI scans showed the lesion. 1 of 3 cases had normal neuroimaging, and so you can see how dangerous this diagnosis is. I want to show you one of the cases that I saw when I was at Iowa. This is a 76-year-old woman who has acute myelogenous leukemia, AML. She's on induction chemotherapy, day 13. The resident was called to see the patient because she has a 2-day history of worsening right-sided periorbital swelling and erythema. When they went up to the floor, she does have the erythema and edema. She has the inferior chemosis. A CAT scan had already been done, but I told you a CAT scan is not good enough in this setting. This CAT scan showed a little bit of fat stranding, and it was read as pansinusitis. And so it's going to be very tempting for the resident to think this is Tolosa Hunt syndrome. But when we saw the patient, we had ENT go look up the nose because this person has no immune system because they're on induction day chemo 13. ENT went up there, they saw the pale necrotic tissue, it was biopsied, and you can see the fungal elements and the angioinvasion. All of this pansinusitis was actually fungal disease. And then the last case, of course, is that amaurosis fugax case, the retinal migraine patient or the ocular migraine patient. In this case, it's a 60-year-old woman judge, and she has for the very first time a curtain coming down over her vision. It lasts 10 minutes, and then it spontaneously resolved. So that altitudinal onset and altitudinal disappearance where it's a curtain, and the curtain can come from the side or the curtain can come from the top. These are the danger signs that this is amaurosis fugax from ischemia. They went and saw the eye doctor and they found a normal eye exam. And as I said in the first talk, impression, normal eye exam, that's going to be dangerous to write that because it's going to cause premature closure of the differential diagnosis, and also it's going to make you think what could be possibly wrong with this migraine or retinal migraine. And that's something I just don't want you to do. You should not be making this diagnosis by yourself. This really needs to have a workup because the alternative, of course, is transient ischemic attack, TIA, or stroke. Hill et al. Looked and published in the Journal of Neuro-ophthalmology in 2007. They looked at all the cases that have been published of quote-unquote retinal migraine. They found 16 patients in the literature. And of those 16, just like the Lamansa series in Cephalgia on Tolosa Hunt syndrome, most of the patients reported in the literature as retinal migraine weren't. Only 5 met the International Headache Society criteria. And even though no patient with the retinal migraine lost their vision, if they don't have retinal migraine, they're definitely going to lose their vision if we don't find the cause. In the modern criteria, we just call this retinal vasospasm now. So when would I accept the diagnosis of retinal migraine? I accept this diagnosis if you meet the IHS International Headache Society criteria for retinal migraine, which means greater than 2 attacks of fully reversible monocular vision loss followed by the migraine headache. So in the review, in the JNO, the most common error is just calling it migraine when there was no migraine headache. Now that can occur as a migraine equivalent, especially in the elderly, but you really don't want to be making this call by yourself. This needs to have a second person look at it. And we don't even consider it migraine really anymore, even though it probably is a migraine equivalent. The mechanism is suspect, and so probably it's vasospasm. And in the brain, the migraine aura is a spreading depression of Lau, and that's why it causes a bilateral simultaneous, usually scintillating scotoma, which means flashing with a jagged line, fortification scotoma that builds up and marches across the field, lasts 20 minutes and goes away. So in these patients, they don't have any of that, and so you're going to be stuck with a monocular vision loss. And so to me, you need to work it up. And because in the JNO paper, but also in my experience, no permanent vision loss occurs in retinal migraine, even though that can occur. I would recommend you perform a visual field, and if they have any evidence of permanent vision loss or a field defect, that needs a workup for stroke. And if you look at the odds ratio for ipsilateral carotid stenosis, the questions you're going to be asking this migraine patient before you give the diagnosis of retinal vasospasm. Is it altitudinal? Is it a curtain? Either altitudinal its onset or altitudinal its disappearance. How long does it last? If it lasts minutes at a time and takes seconds in onset, that's very big odds ratio for it to be ipsilateral carotid disease. Retinal claudication, which is like jaw claudication, except it's moving your photoreceptors to light instead of your jaw. And so what that means is the patient says, I went outside, the light hit my eye, and I was blinded for like a minute. That is retinal claudication. And one of the fascinating things about this odds ratio study, which was from the Dutch Transient Monocular Blindness Study Group, if they had an unknown mode of onset, they just couldn't tell you anything, like how long did it last, was it altitudinal, did a headache follow? If they just keep saying, I don't know, the odds ratio for that being carotid disease is actually less than 1, it's 0.5, and when the odds ratio is less than odds ratio is less than 1, that means it actually means it's less likely to be carotid disease. So in patients who have this retinal migraine, the main thing you're trying to make sure it's not is that it's not a stroke. And that means hemodynamically significant carotid disease. And here you can see the ulcer and the ulcerated plaque. If that plaque flies off, it goes in your eye. If it's transient, you get the transient vision loss. If it leaves the embolus in your eye, you get a cherry red spot and a CRAO. So we really don't want to be making the diagnosis of retinal migraine on the first attack because, number one, you're not meeting the criteria. But number two, that could be a TIA, and that person needs to have a stroke workup. So that is the second talk, and I think I'm just going to go to the next one as well. I'll give you a little breather here while I take a drink. So in this last talk, this talk is about 5 medicines that can blind your patient. The reason it's dangerous is because you're not actually prescribing the medicine. Someone else is prescribing the medicine. And they form the basis of what I call the hate list, HATE, and you'll see what letters those correspond to. And as I mentioned to you before, the most important part of my talks is to convince you that you're a doctor first, and that the reason we're here, not just today, but on this planet, are to make a difference in the lives of people. I have no financial disclosure in any of these talks, but especially in the medicines I'm going to be talking to you about. Not that there's anything wrong with that. So here's the hate list. HATE, H, hydroxychloroquine, and its cousin chloroquine. Amiodarone, which produces an optic neuropathy that looks like AION. Tetracycline, but especially minocycline, especially in conjunction with vitamin A analogs, which is a standard treatment for acne, which causes pseudotumor cerebri. And the biggest one in our part of the world as well as yours, ethambutol, which is used for tuberculosis, but also atypical mycobacterium, produces a toxic optic neuropathy. And then the little e is the erectile dysfunction agents, including Viagra, which I'm going to show you, which also produces NAION. And the reason it's important to be a medical doctor first is a disturbing trend has occurred amongst ophthalmologists and compounded by the development of the electronic medical record is we're just not asking about the medicines anymore. And that's dangerous. So sometimes my residents will write in the chart, C list as the medicines. What list? Well, the list in the chart. Well, we need to look at that list. Or it says some type of lung medicine or heart medicine or some kind of antibiotic. What if that lung medicine is ethambutol? What if that heart medicine is amiodarone? What if that antibiotic is minocycline? Then that's actually the cause of the patient's vision loss. And so we really need to know what the medicines are. And the dangerous part about the electronic medical record is it just keeps adding the medicines in there, and it just looks like a tremendously messy list. And there's no way for us to mark the high-risk medicines out of the chart. So I think it's really important that we go back to basics sometimes. And one of the basic things that we are losing is reconciling these med lists and making sure that they're not on a dangerous medicine. Toxicity in these patients is dangerous, and the reason is the prescribing physician, the person actually giving this person the drug, often does not warn the patient appropriately. The screening eye doctor, who is you, doesn't know they're supposed to be screened. And eye doctors, of course, are not asking about the medicine. So that's why I want you to be a medical doctor first. And then the most important things from the exam standpoint are the risk factors for toxicity, both in the history and the exam, are not typical parts of the regular ophthalmic history. And so hopefully you'll learn what you need to ask and what you need to do on these patients from this talk. And finally, the most dangerous part about it is the findings that we're looking for example, the bullseye maculopathy in hydroxychloroquine and chloroquine toxicity, or the optic atrophy and ethambutol toxicity, those are after the event has already occurred. And so we really don't want to have it happen on our watch. We want it to be prevented, not allow it to happen, and then we make the diagnosis. So this is from my friend Fritz Bonfender, who wrote, one of the top 5 reasons an ophthalmologist would go to court is from an adverse drug reaction. If the Academy of Ophthalmology is going to take a position on Plaquenil, which is hydroxychloroquine, then ophthalmologists are going to be held to that standard. We better be aware of it. And I think that's true for all of these medicines. You need to know that there's a standard of care for all of these medicines that we must follow. So what's in the name? Hydroxychloroquine is Plaquenil. Amiodarone is Cortisone or Pacerone. Tetracycline is acne medicine. Ethambutol is Myabutol. And the erectile dysfunction agents, Viagra is sildenafil, but it has a class effect, which means Levitra, Cialis, all the PD5 inhibitors, all in the same class, have the same effect, which is they can cause non-arteritic anterior ischemic optic neuropathy. And I know it's harder and harder to keep track of these medicines, and that's why I've tried to make it easy for you by making it into the hate list. So we're going to just start with sildenafil, which is Viagra. I don't have any proprietary interest in these drugs. And the biologically plausible mechanism by which a PD5 inhibitor like sildenafil could cause non-arteritic anterior ischemic optic neuropathy is hypotension. Within about 2 hours of taking the drug, there's between a 5 and 10 millimeter of mercury drop in your blood pressure. For whatever reason, these drugs tend to be taken at night and could potentiate the presumptive risk factor for NAION, which is nocturnal hypotension. And so there is definitely a biologically plausible mechanism for erectile dysfunction agents to cause NAION. You should also know that there's a potential for drug interactions, including a very common antihypertensive called amlodipine, and it is recommended that patients on sildenafil be on a lower dose of amlodipine. In the FDA, the Food and Drug Administration data bank in the United States tracking these cases, there are probably 50-some cases now of erectile dysfunction agents causing NAION. The problem, of course, is that erectile dysfunction agents are being used because you are a vasculopath, and presumably that's the reason you have erectile dysfunction. So the risk factors for the erectile dysfunction and impotence overlap with the risk factors for NAION, most commonly diabetes and cardiovascular disease. In the preclinical trials, 1 billion doses were given, 23 million prescriptions were written, and 13,000 males were in the preclinical trial. There were no NAION cases. However, there are cases where there is a close temporal relationship between the cause and effect that is coherent with the pharmacokinetics of the drug. And what I mean by that is the peak of the hypotensive effect occurs within 4 hours, and so the patient takes the drug at night, and the next morning they wake up with NAION. That's completely plausible from a temporal relationship that is coherent with the pharmacokinetics of that agent. And for whatever reason, they are taken at night. And so I think there is a weak temporal relationship for most of the cases. But what it also means is if you take the drug and you get NAION a year from now, that's not related. In the trials, the cutoff is 30 days. So if you've taken the drug within 30 days of the onset of NAION, that is considered a possible temporal relationship. If you look at analogy from animal or human data, because we don't have an animal model for erectile dysfunction related NAION, we have to rely on analogy from human experience. And in the FDA, I gotta hold on 1 second. In the FDA database and in the case control data studies, uniformity amongst these cases is lacking. And that means there's some cases that are very far away from the taking of the dose, and there's some cases that are very close to taking of the dose. Coherence in class is one of the criteria that we're using to determine cause and effect. And as you know, toxic optic neuropathy from other toxins like ethambutol doesn't look anything like NaION. Most toxins are bilateral, symmetric, simultaneous central scotomas, or secocentral scotomas with a normal disc. The closest analogy that we have to erectile dysfunction agents is NaION from amiodarone. So I don't think it's a toxic optic neuropathy. I think it probably is the blood pressure. And finally, there's dose response curve. So if you take more of the drug, you are more likely to get it. So for ethambutol, that toxic range is 15 mg per kg. Once you start getting up to 25 milligrams per kilogram, you're talking about a 6% or 10% chance of getting toxic optic neuropathy. Likewise for hydroxychloroquine, which has a threshold of, we used to say 6.5 mg per kg, but now anything over 5 mg per kg is probably going to be a risk, even though that's a graded risk. So erectile dysfunction agents do not have a dose response curve. So to me, it's the pharmacokinetics and the dose response curve and the dose gradient don't exist. And there have been cases where you just took it like once and you get symptoms. And finally, the effect specificity. Whatever we see has to be very specific. The more specific the effect, the more likely the drug is to be causing it. So for example, if you take a drug and all your mucous membranes fall off, well, that's Stevens-Johnson syndrome. That's very highly correlated with certain drugs. And likewise for amiodarone, if you have a vortex keratopathy and NaION, you're way more likely to have a specific effect from that drug. In hydroxychloroquine, a bullseye maculopathy is a very specific effect. Tamoxifen, if you put tamoxifen in and get crystals in your retina, you can't blame that on anything else. But for erectile dysfunction agents, NaION is not a very specific effect. There are recovery and rechallenge cases, but they're rare. So normally we would take the drug away, you get better, and then give the drug again and get it again. There are inadvertent rechallenges, but they're just so rare. If you look at the case control studies, this is one from Bafiatis and McGuinn, 38 cases of NaION against controls, they found no relationship. The problem is this paper had to be retracted from the BJO, and you can read all about that story. So if you look at erectile dysfunction agents in general, they probably are associated with NaION. And because the Food and Drug Administration in the United States was so worried about this, they mandated that the companies undertake studies to look at it. So this study was published in the Journal of Sexual Medicine, and they had 103 centers in the US and in Europe. There were 43 definite cases of NaION within the time window that I told you, 30 days from exposure, which is 5 half-lives, to a PD-5 inhibitor, in this case, sildenafil. The calculated odds ratio for having NaION was 2.15, and if you included cases that probably were NaION, then you're talking about odds ratio 2.36. So, erectile dysfunction agents, Viagra is just one example. It's the most common, but they all have it. The class effect is the same for Levitra, Cialis, and Viagra. There is a weakly plausible biologic mechanism of hypotension as a cause for NaION. If the cases occur close to the taking of the drug, for example, the same day or the next morning, those are stronger cases. However, up to 30 days is still probable. There are a few analogy cases, but it's after 1 billion doses, we probably still have less than 100 cases. There's no dose response curve. There's weak coherence in class. There's a rare rechallenge case, and there are no recovery cases. The bottom line is someone needs to tell the patient about the risk. And if you don't tell the patient, they're just going to Google it anyway. And as you know, Google can be an angel or a devil. So, the trouble with quotes on the internet is you can never know if they're genuine, and of course that's not Abraham Lincoln. However, the point is Google is a dangerous thing, and people get all sorts of misinformation from Dr. Google all the time. I'm going to switch gears and talk to you about amiodarone. Amiodarone is both a medical and a medical legal problem in the United States. Amiodarone produced the largest lawsuit in ophthalmology against a pharmaceutical company, $22.8 million judgment for just a single drug in a single case, and that was in 1997. After that, they had to change the labeling to emphasize the possible occurrence of amiodarone-associated optic neuropathy with the drug, and so now that liability is shifted onto us as doctors. As I mentioned to you before, amiodarone produces a very specific vortex keratopathy. So this is pigment in the epithelium in the cornea. And so if you see this vortex keratopathy, it's a good indication they're on the drug. If you look at the papers that have been published on amiodarone-related optic neuropathy, it has a very characteristic clinical appearance. It's normally insidious, slowly progressive, bilateral, and the disc edema takes a long time to go away. So those are the strongest cases for amiodarone optic neuropathy. The weaker cases are the ones that just look like NaION because, of course, the person's on amiodarone because they have some cardiac disease. And the reality is amiodarone saves people's lives. So you really shouldn't be stopping amiodarone on anybody. That is not your decision. Your job is to make the call to the person that makes the call, and that is not you. That is cardiology or medicine or whoever's prescribing the medicine. This also has no dose dependency and has no dose response curve. It's seen in a very, very small minority of patients despite that big lawsuit number. There's no proven pathogenic mechanism. It looks just like NaION, but the strongest cases are bilateral, insidious, and it doesn't go away even after you stop the drug for months. But it can look just like NaION. And so in the United States, if someone has NaION and they're on amiodarone, we're going to talk to cardiology about stopping the drug. If you look at the Mindell et al. Paper in the American Heart Journal, they had 837 patients with amiodarone versus placebo, 832. Median follow-up, 45.5 months. The endpoint was, did anyone get bilateral, insidious, swollen disc, loss of vision? Nobody was removed for endpoint. And this paper concluded that bilateral vision loss for amiodarone toxic optic neuropathy occurs infrequently, if at all. I think that's a bit strong because I think there are real cases. So what do I tell the patient? I tell them, look, you have a risk of amiodarone optic neuropathy. I ask every patient who's had an NaION if they're on this drug, as well as asking about the erectile dysfunction agents. I call their cardiologist and tell them about it. And then I tell the patient, you need to make a risk-benefit decision with cardiology about whether you should continue the drug. Normally, we get one of two answers from cardiology. Answer number one, he'll die if we take him off that, so we're stuck with it. Answer number two is usually, he doesn't need that medicine anyway, just tell him to stop. I never tell him to stop, by the way. That's for the prescribing doctor to do. Hydroxychloroquine is a totally different ballgame. Hydroxychloroquine, even though its toxicity mechanism is not fully understood, its toxicity profile is understood. It produces a bullseye maculopathy, which is a ring-shaped parafoveal zone that tends to spare the central 2 to 3 degrees, and it makes a very characteristic fundus and OCT finding, which is a bullseye maculopathy. It's bilateral, simultaneous, and it's often irreversible once the RPE damage occurs, and it continue not just for the 30-day half-life like sildenafil, but for months. And it looks like this. You can see this bullseye of RPE change around the parafoveal region. Close-up look at it, you can see the RPE change. We really never want to see this. We're trying to prevent this from happening. It looks like this on a Humphrey visual field, a ring scotoma. So you can just put your finger right through that ring. And normally we're going to do a 10-2 field because we're looking for that parafoveal region with sparing of the central 2 degrees. And that means a 10-2 visual field. It can also present with a central scotoma. It doesn't have to be a ring scotoma. You need to think about doing an ancillary testing. Your choices are fundus autofluorescence, multifocal ERG, or OCT. I prefer spectral domain OCT. And you can see here what we're looking for is the normal foveal contour, the normal intersegment IS-OS, intersegment outer segment ellipsoid. And it's like a train track. You should be able to run the train all the way down this track. However, in patients who have plaquenil hydroxychloroquine toxicity and are developing a bullseye, in that parafoveal retinal pigment epithelium, we're going to get disruption of the IS-OS junction in the ellipsoid. This will cause the train track to buckle, and it'll kind of take on this flying saucer appearance. So if we see that UFO sign, we're going to be really worried that that's a bullseye maculopathy. Here's another UFO sign here with the disruption of the ISOS junction at the ellipsoid. This is the spectral domain OCT finding that we're looking for in hydroxychloroquine toxicity. Multifocal ERG, an electrophysiologic study, is more sensitive to the detection and can see the hydroxychloroquine toxicity before the structural imaging, of course, the OCT, and way better than fluorescein or U. But multifocal ERG is not universally available, so even though it is in the recommendations and I have used it in my practice, it's just not available to everybody. Fundus autofluorescence, however, probably is available to you, and you can see how the fundus autofluorescence findings can be quite variable, ranging from minimal to moderate to the obvious bullseye. And the fundus autofluorescence can see what you cannot see, but probably spectral domain OCT can see it better. And of course, chloroquine is way more dangerous. Chloroquine has a way smaller and narrower toxicity window and therapeutic window, and that's probably why hydroxychloroquine was developed in the first place. And really, we don't want to see that bullseye. If you see the bullseye maculopathy on your watch, then that's a problem, because we should be screening the patients and taking them off the medicine before they lose their vision. Once they lose their vision, that is game over. And I mentioned to you that MERG is definitely more sensitive, but it's just not universally available. If you look at the risk factors, and this is where the difference is between what you used to do for a regular eye patient and what you have to do for a hydroxychloroquine or a Plaquenil patient. Number one, the dosage. And the threshold used to be 6.5 mg per kg. I think that's still valuable for defining higher risk people, but anybody over 5 mg per kg is at risk. The cumulative dose is 1 kilogram of total dosing, and so you need to calculate both their milligram per kilogram dose and their cumulative dose, and that usually doesn't reach threshold until year 5. So we really shouldn't be screening the patient every 3 months when they're in their first year of treatment. But after they pass year 5 or pass 1 kilogram, or if they're in the high-risk dosage category, you really should be following that patient a lot closer. Body habitus, of course, impacts mg per kg on the weight, and obese patients do worse. If they have renal or liver disease, which affects the excretion of the drug, that's going to be a problem. And if they have pre-existing maculopathy, I try and convince the prescribing doctor not to use this drug on this person. And older patients obviously are also at higher risk. So the current recommendations have changed over time. So I'll just show you kind of what we do, and I'll tell you a little bit about what's changed. So I use either MERG, spectral domain ACT, fundus autofluorescence, which plus a visual field. The 10-2 plus one of the above is probably sufficient. The 10-2, if it's abnormal, you should take that seriously, and you should talk to the patient and talk to the doctor. In Asian patients, we have to do a 24-2 because they have a kind of a periaxial form that's a little bit outside the 10-2, so they have to do both a 10-2 and a 24-2. One day, the electrophysiologic testing, the MERG, will replace this, but that day is not today. We don't use the ANSWER grid for testing in the clinic, but I do give them that to take home. And if they're on this tamoxifen, which I told you causes that crystalline retinopathy, they probably should be evaluated as a high-risk person. And of course, chloroquine is way, way more dangerous because its therapeutic window is way tighter. And so the toxicity numbers are a little bit different. It's 3 mg per kg and 460 grams rather than 1,000 grams as the cumulative total dose. The reason we blow it in hydroxychloroquine toxicity is not recognizing the risk factors, not asking the questions, not stratifying the person into high risk versus low risk. And you get this false sense of security if you keep screening these low risk people over and over and over again. So it tends to seem like it's worthless. And then one day they're at year 5 and 1 kilogram, and they're all of a sudden in the high risk category. In addition, the pill size only comes in one size, which is 200 milligrams. And so people end up either on 200 milligrams a day, which is not going to cause a problem, or 400 milligrams a day, which could cause a problem in pretty much anybody. And so it's really dangerous the way they're prescribing this drug. I think with the development of these pill cutters, it's gotten a little bit better. The fundus finding, the thing I told you we're looking for, the bullseye maculopathy, that is a marker of permanent vision loss, and we should not wait until we see that. If you look at this NICA paper from JAMA, of 18,000 insured patients within this one healthcare system, they had rheumatoid arthritis or lupus. 1,409 of them had used hydroxychloroquine for 4 years or more. So they're already getting to the high-risk characteristics. If you look at these people, 27.9% of them never had an eye exam. That's just ridiculous. 6% never had an eye exam in their whole life, even though they're on this high-risk medication. And 34.5%, a full third, did not have the diagnostic testing for the maculopathy that I just told you was the standard of care. So this is a tremendously bothersome paper, because what it's showing is, even if we have a good evidence base, even if we're telling everybody what we know, people aren't doing it. And I just want to end with these two easy but dangerous ones, which is thin patients or males who have pseudotumor cerebri. So if you've got papilledema and it kind of looks like pseudotumor, but it's a man instead of a woman, it's a thin person instead of an obese person, you really should be thinking about exogenous medications. In the PDR, which is the physician's desk reference, it says this about vitamin A analogs and tetracyclines. Accutane use has been associated with a number of cases of pseudotumor cerebri. Some cases involve the concomitant use of tetracycline. Concomitant treatment with tetracycline should therefore be avoided. Well, nobody does that. In the U.S., everybody gets both the vitamin A analog and the tetracycline derivative for their acne. That's why they're being treated for their acne. They kind of need the medicines. So you got to be careful with these people, because they often deny that they're on any medicine because they think it's acne medicine. But an acne medicine is still a medicine. The last one is the most important one. It's ethambutol. It causes a classic toxic optic neuropathy. Painless, progressive, bilateral, central, or secocentral scotoma. Ethambutol has a proven causality. It is dose-related. 15 mg per kg, 1% risk. 25 mg per kg, 6% risk. It causes a blue-yellow dyschromatopsia, the central field loss, and the disc is normal, and then it turns pale. Please don't wait until the disc turns pale to make the diagnosis. That's game over. So how are you going to screen these people? Unlike hydroxychloroquine, where there's pre-screening findings that occur before the visual loss occurs, there is no pre-ethambutol toxicity finding. It's either they have it or they don't. And so the current recommendations are that we screen high-risk patients defined as greater than 15 milligrams per kilogram per day, or who have concomitant renal failure, or who are going to be long-duration therapy because they have multi-drug resistant TB or Mycobacterium avium complex, or they're a lung transplant, or whatever reason. Those patients need to be evaluated every month. Now, it doesn't have to be every month by a doctor, but it has to be somebody checks their vision, even if that person is the patient themselves. I warn all the patients about the toxicity. Lawton Smith used to say, if your doctor comes in the front door with ethambutol, you should run out the back door. However, ethambutol is probably still useful in some patients, especially the multi-drug resistant TB that we're seeing. So we do a baseline examination and a baseline visual field on all of these patients. We're going to do the color vision testing for baseline. We're going to take a photograph of their fundus. We're going to do a 24-2 or a 10-2. We're going to give them an answer to take home, and we're going to tell the patient if there's any change, you have to call. And so the Homeland Security risk stratification for ethambutol is completely dose dependent. The higher the dose, the more danger we are. And if you are on greater than 15 mg per kg, that is danger Will Robinson. So you should not be confusing the two strategies that I have told you. Ethambutol cannot be screened every year. You don't have toxicity come back a year. It's not at all like hydroxychloroquine, where we have specific regimens and a structured testing regimen, and we can predict and find the toxicity. This is not the correct strategy for ethambutol. And the worst part about ethambutol is their weight often changes during the treatment. So in my practice, it's not TB that we see the most, it's Mycobacterium avium complex that we see. And those patients often have lung disease that's chronic, and so they lose weight, but their dose says it doesn't change. And we don't change the dose, but the weight is going down, you're actually changing the dose, because the milligrams per kilogram is going up because the kilogram is going down. And so if you look at the British Thoracic Society guidelines for chemotherapy management of tuberculosis, they also recommend inquiring monthly about visual symptoms. And that means they have to have some assessment of their vision every month, even if it's just assessing themselves. And you're going to see ethambutol toxicity because we are seeing ethambutol toxicity. Toxicity from ethambutol comes from just 22 countries from the tuberculosis cases. That's 80% of the TB comes from just 22 places. Unfortunately, or fortunately, a lot of those people are moving to the United States. And probably you're seeing the same thing in your non-Emirati expat population. Your worker population comes from endemic populations, countries. My friend Alfredo Sadun calculated once some scary math. Because there are so many people on this drug who have tuberculosis, 100,000 people potentially could be blinded iatrogenically from toxicity from ethambutol. That's combined, all the other toxicities put together, it's still not 100,000. So that means this is the hate list. Hydroxychloroquine and chloroquine, which produces a bullseye maculopathy. You need to know the screen and stratify based on risk, personal patient profiles, and also do some special tests. 10-2, spectral domain OCT, fundus autofluorescence, MERG. Amiodarone optic neuropathy produces what looks like NAION, but if it's bilateral, insidious, disc edema that is not going away, that is the classic for amiodarone. Please have a conversation with the patient and the cardiologist about a risk-benefit decision. Tetracycline and vitamin A analogs are used to treat acne. The patient needs to be inquired about this because they often don't tell you because they think acne medicines aren't medicines, even though they really are. The concomitant use of the minocycline plus the vitamin A increases the risk, even though that risk is low. You should be thinking about it in thin, male, or older patients. Ethambutol is the king of toxicity. It's going to blind more people than all the other ones put together, and maybe it's 100,000 people. You need to tell the patient to check their vision every month and perform a baseline examination. That one is completely dose dependent. The erectile dysfunction agent is the little e in hate. It includes the PD5 inhibitors, all in the same class, Viagra, Cialis, Levitra. They probably cause NAION. The odds ratio is between 2.1 and 2.36. The patient and their doctor have to make a risk-benefit decision and quality of life decision on whether they should continue that medicine or not. And that concludes the talks that I was going to tell you about today, and I will turn it back over to Sumayya, and we can open it up to any questions that you might have.
And interesting talks. We now will open the door for the questions. We have here questions asking about how do you calculate what the dose of hydroxychloroquine is toxic to a certain weight of the patient? Sorry, I cannot see the questions clearly.
So the toxicity is milligrams per kilogram of body weight. We used to do that ideal body weight thing, but probably just straight calculation, mgs per kilogram. The number is 5 milligrams is the threshold. 6.5 used to be the threshold, and that's a higher risk if you're above 6.5 milligrams per kilogram, but anybody over 5 milligrams per kilogram is at some risk. There is no safe dose of hydroxychloroquine. The main number you have to calculate, though, is the cumulative dose. You have to add up all their doses together, and that threshold is 1 kilogram of cumulative dose of hydroxychloroquine. Normally, that does not happen until year 5.
Thank you, Dr. Lee. There is another question here. What is the youngest? Wait a minute. What is the youngest age one can get optic neuritis?
So optic neuritis is a disease that has predilection for young adults between age 20 and 45, say, but any age patient getting an optic neuritis. In children, it's much more likely that it's post-infectious optic neuritis than it is multiple sclerosis, but multiple sclerosis can occur in children. It's just rare. The Antibody disorders can also occur in children, including pediatric neuromyelitis optica and pediatric MOG, myelin oligodendrocytic glycoprotein. Those optic neuritis patients tend to look like ADEM, acute disseminated encephalomyelitis. So any age is the answer to your question. Patient can get optic neuritis. It's not a disease that's restricted to any one age range.
Okay. There is another question here asking about how common is BION in young patients, especially the renal patients.
So any patient who has hypotension can get ischemic optic neuropathy. There's two forms of ischemic optic neuropathy: anterior, where the disc is swollen, and posterior, where the disc isn't swollen. The anterior form is 90% of the ischemic optic neuropathies. Only 10% are PION, posterior. But if you look at the posterior ischemic optic neuropathies, there's three flavors of that: arteritic, so old patient, giant cell; non-arteritic, PION, is from surgery usually, and that surgery is usually spine surgery or cardiac surgery. However, renal patients have marked fluctuations in their blood pressure because of hemodialysis. So that problem is called intradialytic hypotension. And intradialytic hypotension can produce PION. So PION in young people who are on hemodialysis is common. So we really have to worry about ION, both the garden variety NaION and the intradialytic hypotension related PION in renal patients. But it's the dialysis thing that you got to worry about there.
The same question regarding PION. Is there any sex difference?
There's no apparent gender difference in PION and NaION between males and females. However, males tend to have more vasculopathic risk factors. Females tend to live longer and have more giant cells. So there probably is some stratification based on age, but in terms of gender-based predisposing factor, probably not.
Okay. There's a question regarding ethambutol screening. Is visual field testing is necessary, or both we can start with visual acuity?
So most of the papers say just acuity. So they can just do an Amsler grid on themselves and just someone checks their acuity. And because they're just checking their acuity, that means a nurse can do it, or the patient can do it, or the family member can do it. So the official guidelines are to inquire monthly about their vision. I prefer that they check their vision. So we make a copy of the near card and the Amsler grid and we just give it to them. There are also online apps where the patient doesn't have to have paper. They can just check their own acuity, check their own color vision, and check their own Amsler online at home by themselves once a month. And so then the prescribing docs can just say, did you check your vision? And they say, yes. What was it? So then they don't have to come in. They can just say, it was 20/20, I had a normal field, and I had normal color. In fact, as you probably know, during COVID-19, we've switched a lot to virtual visits. And so for my patients, I can literally have them check their vision, their color vision, and their visual field at home on the computer. And then they just send us that data. So for virtual visits in COVID-19, probably the same thing could be done for ethambutol.
Thank you. What is the safe follow-up intervals for hydroxychloroquine?
So the intervals of time for screening for hydroxychloroquine are determined by the risk. The risk is determined by those criteria that I showed you. So in a low-risk person, less than 5 years of therapy, less than 1 kilogram, less than 6.5 milligrams per kilogram, who is a thin, not obese person, who's young, has no renal toxicity, no liver toxicity, and who has no pre-existing maculopathy, that person can be seen according to the American Academy of Ophthalmology guidelines for just regular eye care, which is like once a year. That's a low-risk person. In contrast, a high-risk person is someone who's on high dose, greater than 6.5 milligrams per kilogram, or has a high cumulative dose, which is greater than a kilogram, or they have pre-existing renal disease because they had glomerulonephritis from lupus, or they have renal failure for some other reason, or if they have a pre-existing maculopathy. All those people are high-risk people, and those people need to be screened at every 3 to 6 month intervals. In fact, I usually try and get them off the medicine if they're in that range. So I think you have to determine the risk is the answer. There's no single number for determining what should be the duration for the next screening visit. It depends on risk, high, medium, or low. If it's low, once a year.
There is another question here regarding unilateral pallid disc edema with inferior hemianopia in 48-year-old male with no past medical history, no drug history, no surgery, no REBD, normal ESR, CRB, and normal MRI and fluorescein fundus angiography. So how to proceed in this patient?
Yeah, so when you're a young person and you don't have any vasculopathic risk factors and you have pallid edema, that's very bothersome that you have some other optic neuropathy other than ischemic optic neuropathy. So normally pallid edema is the marker of ischemic infarction, but when you have pale and swollen at the same time, it's actually not a marker of just ischemia, it's a marker of severity. So whatever it is, it's super bad. And in a 48-year-old, you're really thinking about non-arteritic, but if you have no risk factor, that means you're not even thinking about ischemic optic neuropathy. That means we are worried about other optic neuropathies. And the other optic neuropathies that are this severe are the antibody ones. So normally optic neuritis is what you'd be thinking about in a young person, but that normally is retrobulbar. So we have an anterior optic neuropathy, which is severe, and so that means the mimics. The mimics are sarcoidosis, NMO, and MOG, the antibody things. So those are the things you should be thinking about in a patient who's young, who has no vasculopathic risk factors, but has a severe swelling that is both pale and swollen, pallid edema. Most common in my clinic would be MOG, myelin oligodendrocytic glycoprotein. Our number 2 would be sarcoidosis. So that person we would give steroids to. In the older literature, some of those patients are referred to as optic disc vasculitis. So it's like giant cell, except it's only on their nerve. Those people need a search for systemic vasculitis, NMO, and MOG.
Okay, I think we don't have any more questions. So no more questions from the audience. So it is, I think your talks already be understood from them. So no more questions. If we don't have any more questions from the audience, so we can just end our talk. And thank you, Dr. Lee, for this informative and interesting talks, really, and we had a wonderful discussion. And I hope we have you more in the coming webinars, and enjoy the rest of your day and stay safe. And I hope we'll see you soon in UAE.
Thank you so much for organizing it, and Sumayya, it's always so great to see you. Take care.
Thank you, Dr. Lee. Thank you, Dr. Lee. I would like also to thank Emirates Society of Ophthalmology and the chair of the scientific meeting, Dr. Omnia Hammam, for giving us this opportunity to arrange this webinar. And I would like to thank the Allergan Group, Mr. Ahmed, Ms. Asil, and Mr. Mark. And also I would like to thank the audience for joining us tonight. Thank you. Thank you, Dr. Lee. See you soon.